Okay.
So good morning, everybody, and welcome to our Life on Hold event. It's so amazing to see so many people joining us this morning. We're really excited to be doing this. My name is Alice, and I coordinate the service in Wales for Fertility Network UK. For those of you who don't know much about Fertility Network UK, we are the leading patient-focused fertility charity. We work with anybody and everybody with regards to fertility issues. So we work with anyone who's affected in any way, whether it's people considering their future fertility and thinking about their lifestyle choices and their current health and how it might impact in the future. We work with those who are maybe at the beginning of their journeys. They may have been trying to conceive, starting to worry, going to GPs, that sort of thing. We are supporting those who've been on the journey for some time, so they may have had one or two or more rounds of assisted fertility treatment. We help those who have had success, their treatment has worked, they are pregnant and their anxieties are way up there. We support those people, and sadly, but really importantly, we support those who are childless not by choice. So maybe the fertility treatment option pathway was never going to be right for them and they didn't want to do that, or they did go down that pathway and the treatment was unsuccessful, which unfortunately it does happen. So they are living a life they didn't think they would be living. They don't have the family they initially dreamed of and planned for. And it's really important that those people are supported, and we link people up with a network of peer support. So that's kind of what we do throughout the journey. Fertility Network are there for people. So why are we here today? Well, it is, oh, hang on, for some reason I can't seem to move my, there we go. Okay, so why are we here? Well, it's Fertility Awareness Week. This week we're coming to the end, and really Fertility Awareness Week is all about raising awareness of fertility and infertility to a wider audience. We feel it's so important to improve fertility education within society. We all need to be better informed about fertility so that those who are going through it feel better supported, whether that be in their family, in their friendship groups, or within the workplace. We feel like everybody should be better informed so that people are better supported. Today I'm joined by my lovely Fertility Network UK Wales team, Emma and Liz, and also we are so grateful to have Karen Ansell. She is our secondary care nurse specialist based in the Mylor Hospital in Wrexham. And we have our consultant from Wales Fertility Institute, who treat patients mainly in South Wales, Dr. Ariana D'Angelo. So they are both here with us today. Thank you so much. So I'm going to kick us off today. I'm going to talk a little bit about what is infertility, who it affects, and about some of the impacts. Then Karen is going to run through what people have to go through towards the beginning of their journey. So when they go to the doctor and present with an issue, what tests they have to go to, what it's like to be on a waiting list, some of the medications that they might have, some of the investigatory tests and scans and things like that. And then we'll pass over to Ariana, who is going to run through a typical cycle of IVF. And she'll talk about some of the drugs and some of the surgical procedures that people have to go through, and how it affects them both physically and mentally. And then finally, we will hand over to Emma. Emma's going to really focus on the impact on mental health. She'll talk through about how men and women who are going through this, how it makes them feel. She'll talk about some of the social pressures and some of the way that some people really feel pressured to to have a family and how it makes them feel if they can't have that family. So she's going to try and answer some of the questions, talk about things like what not to say, that sort of thing. Now, we don't have much time today. We can't possibly cover everything, but this is the first of many sessions. So I'm going to tell you now, but we will remind you at the end. If you enjoy this, please let Emma know. You've all got Emma's email address. Let her know what you liked, let her know what you didn't like, and let her know what else you want to know about, because we would love you all to have lots of opportunity over the coming weeks and months and years to ask the questions you want to ask. Today is all about increasing your knowledge a little bit and basically making a safe environment for you to ask any question you want without fear of offending or upsetting the people you care about. So this is the time to say whatever you like and ask what you need to. Okay, so before we get going on that, we want to play a little video for you. I'm going to stop my screen share now, and Emma is going to play a video. So if you could all have a listen to this, and then we will talk a bit more about it in a sec. Okay.
It's hard as well because we decided not to tell anybody our first round, and I actually found that harder than sharing it with everybody, because people say things, they don't mean to be insensitive, but I feel as if once you hit a certain age, or especially once the wedding ring goes on the finger, everybody thinks it's their business to know what your plans are to have a family. She turned around quite innocently and said, "Oh, your turn next." And to play things down, I just said, "Oh, we'll see." And she turned around and she said, "Oh, don't be selfish now. Your parents deserve to be grandparents." And sorry, it's things like that really get to you. Because I knew my brother didn't want to have children, so you do feel a bit of pressure to make your parents have that experience of being a grandparent, and it is really hard. Sorry. Sorry, Em. Having that moment to announce your pregnancy is a wonderful thing. I think you lose out a bit on that with IVF. As I remember, I saw a video actually last night on social media with parents' reactions to becoming grandparents, and they have these huge surprises, and they open the boxes, and it's, you know, like a teddy with "Happy Birthday Grandpa" on it. And I never got that moment with my parents because they knew about the process throughout everything, because I don't think I could have gotten through it without my parents or my in-laws. You feel as if you cheated slightly out of those special moments, you know, because they know you're actually going through it. I found though that telling my friends about each round after that actually helped, because I hate hiding things from people. It actually stresses me out more. And they were brilliant about it. I work as a peripatetic music teacher, so I was in 8 different schools working at the time, which meant I had to tell 8 different heads and my boss that I was going through the treatment, hence why I wouldn't always be in work. So by the time that I was doing my 5th round, I think about 30 people knew that I was having fertility treatment, and they were basically the people I felt that had to know why I was sneaking off, why I'd be half an hour late for work. But I actually personally found that a little bit easier. I know some people don't like sharing the experience, and they like to do it in private and tell as little people as possible. I think you have to do what's right for you. There is no right way to do this, really. You know, find the people who are supportive. If there's certain people you don't feel need to know, then just don't tell them. It is completely your business. I would say though, I'm a bit of a stickler for, they are medical professionals, don't question what they're doing or their decisions. But it's your body, and you know how your body is reacting to certain things, and I would definitely say speak up.
Okay, so it's quite an upsetting video to watch, that one, because Lisa really does put across how she feels, how precious she feels, how stressful it is, and how much she's got to juggle. So she's not just juggling the treatment, but she's juggling her own emotions and everybody else's, and it's just really difficult. So we just wanted to show you that to kind of kick us off, really, and really show why we're doing this today, why we're doing this Life on Hold event, and why we feel it's so important to talk to friends and families and colleagues. Okay, so I'm going to start and just talk about a little bit about fertility, who it affects, and about some of the impacts. Right, so what is infertility? Well, the World Health Organization class it as a disease of the reproductive system. And it's essentially a failure to achieve a clinical pregnancy after 12 months or more of having regular and protected sex. Now, there are different types of fertility issues that people experience. There's primary, and this is where someone's never had a child before, and they are having difficulty conceiving. There is secondary infertility, where someone has had a baby in the past, they've had a child, but for some reason now they are having trouble conceiving again. And there is subfertility, which is essentially generally describes any form of reduced fertility for a prolonged time of unwanted non-conception. So these are the types of fertility issue. And who does it affect? Well, lots of people, basically. Now, it's roughly 3.5 million men and women across the UK, which is equates to around 1 in 6, but that's heterosexual couples. And actually the number's probably higher than this, because it's not just heterosexual couples that are affected by a fertility issue, anybody can be affected. So there are single people going through this, and there are people who are in same-sex relationships going through this. So it's a lot of people, it's common. And who is it? Now, historically, I think it's always been viewed as a bit of a female issue, and there's a lot of misconception out there about infertility. It's not a female issue. About 1/3 of known fertility cases are female factor. About 1/3 of known cases are male factor. But about 1/3 of cases could be both, or they don't know, it's unexplained. And actually, in the latest HFEA trends report, HFEA is the Human Fertilisation and Embryology Authority. They are the governing body for all licensed clinics across the UK. So in their latest trends report, they actually say that male factor infertility could be responsible to actually up to half of all cases. And it's growing, it seems to be growing, whether that be genetic or physical problems. Male factor does seem to be on the increase. But whatever the reason, it doesn't matter. It affects everybody. It is a disease of the reproductive system. Okay, so there's lots of causes of fertility issues. Now, some of them are endocrine disorders, so basically hormonal issues, problems with ovulation, ovulation failure, conditions like polycystic ovary syndrome, PCOS, problems with the thyroid or pituitary glands. So lots and lots of things. You can imagine all the hormones that we need in our body, and there's a number of things that can go wrong. Diseases of the reproductive system, things like infections, endometriosis, which is extremely common and really, really hard to diagnose. Uterine disorders and infections within the fallopian tubes, which can cause blockaging and scarring and things like that. And also sperm disorders, so problems with the semen, so not enough sperm in there, or maybe the sperm are their morphology is there's something wrong with the morphology, so the shape looks different, so they find it hard to get to the egg, or maybe they don't swim in the right direction. Some of them are very lazy and they don't seem to move much. So there's lots of problems that can happen with sperm. And physical disorders, so things that are maybe somebody has got going on can really play a part in their fertility issues. So one thing is BMI. So there's a lot of evidence that shows that women with a high BMI, so their body weight is out of the healthy range, they have problems with ovulation. And also those with a low body weight. So we really focus here on people with eating disorders, especially when we're talking to young adults. You know, if your body weight is low and you don't have enough fat, women don't produce, cannot produce the correct hormones they need. So it's really important that if someone has disordered eating, it's another reason to get help and professional support, because it can affect fertility. And unexplained, in about a quarter of fertility cases, up to 25%, the doctors don't find a reason. They can't find a reason. There's nothing obvious going on. And that is so distressing for patients. Excuse me. It's so distressing because they never get an answer. They don't know what's going on. They never get that real firm diagnosis, which can help them to kind of move on and accept things. Okay. So I'm going to run through what the ups and downs, basically, before we move on. Now, when somebody starts trying for a baby, most people will know about this. You feel so excited. You've discussed it, you have that discussion, and you think, oh my goodness, now is the time, let's do it. And you think about all the barriers and all the problems and, oh, it's going to affect my life, all the usual, but that's exciting chatter. It's exciting planning. And then you try and it's fun. Everyone loves having sex at the beginning and making a baby, and it doesn't work. So you start worrying and your mind starts racing away. It can cause, tensions within a relationship. One person maybe is a bit more worried than the other. And you go to your GP. Now, at that stage, you'll be asked some questions. They'll talk about history, and they'll talk about lifestyle issues and some of the changes you can make to maybe improve things like sperm. And then you'll be on a waiting list. You'll be referred to secondary care investigations. You're on a wait. And that's stressful in itself because you're waiting. And we all know with fertility, female age is the biggest factor, really. And so that's really stressful because your life is on hold. The name of this event, life on hold. You're in limbo. You're not getting anywhere. And that causes so much anxiety. You get your initial diagnosis or not. If it's unexplained, you never get that diagnosis. And you feel positive again. You know where you're going. You're on a waiting list. Maybe you need assisted fertility treatment. And you get your treatment planning appointment and you're hopeful and you're excited again. So they talk about it as a roller coaster, ups and downs. So you're on an up. You go through your treatment, which Ariane is going to talk a bit about more later. So I'm not going to go into that. And you feel so excited. You feel full of hope. You have your embryo transfer and you've got something called the 2-week wait, which so many of the men and women we talk to, it's the dreaded 2-week wait. It's really worrying time. And essentially you have to wait until you can weigh on a pregnancy stick and see if it's worked or not. And IVF doesn't work all the time. And when you see a negative test, you come crashing down. You feel so disappointed, and it's a real feeling of loss. It's a loss of what you wanted. It's a loss of the baby you thought you could have. It's really awful for people. You might get excited again when you're offered another round and maybe the doctors tell you about something different they could do. And you think, oh, wow, more. This is hopeful. We've got a new way to go. Amazing. And so it goes on. You might have another cycle, which may not be successful. And the feeling of bereavement is so extreme. We did a survey in 2016 with Middlesex University, and 90% of those who we talked to said they had feelings of depression. 42% had suicidal thoughts. Now, I don't want to say that to alarm anybody, but it's really important to know that the impact of this pathway, the ups and downs, the not knowing, the excitement, the sadness, it can really take its toll on people. And Emma will talk about that in a little while. So I'm going to stop there now. And I want to pass on to Karen, who's going to run through what people have to go through in the initial stages. So those tests, investigations, and when they have to find out a bit more, essentially. Okay, so I'm going to stop sharing now. And Karen, over to you.
Thank you very much. Can you hear me? Yeah, marvellous. So I'm Karen. I work at the Myler Hospital in Wrexham in North Wales, and I receive referrals from couples who have failed to conceive, These referrals generally come from the GPs or other consultants within the unit who've been treating male or female partners for other conditions. By the time the couple actually gets to me, you can see that the journey is already taking its toll. A lot have had to battle through the system to actually get referred. People have been ignored. Other people have put a downer on their feelings. They've been told not to worry, it'll happen in time, or they're too young, or they're too old, or they won't qualify for any support. And that first consultation can be quite distressing to start with. And part of my job, apart from doing the physical examinations and requesting the test, is to manage their expectations about what to expect on their journey. The first tests that we actually do are some hormonal tests, and these are done in the first few days of their period. They're called the follicle stimulating hormone and the luteinizing hormone. The follicle stimulating hormone is the hormone that helps the egg to develop. So obviously it's very important. The luteinizing hormone is the hormone that fires the egg off. And what we want to see is these in one certain ratio. The reason we do it between day 2 and day 5 of the cycle is because that's the only time in a woman's cycle where we know where these hormones ought to be. And we want these levels to come back as less than 10. The other investigation that I request at this point, if it hasn't already been requested by the GP, is a pelvic ultrasound. The pelvic ultrasound will give us a view of the womb and the ovaries and make sure there's no lumps and bumps that might be either preventing ovulation or preventing implantation of an embryo. At the moment, this is a very frustrating part of my job, as they're not doing routine, due to COVID, they're not doing routine pelvic ultrasounds. But if there's any other type of menstrual irregularities, such as bleeding in between periods, bleeding after sexual intercourse, or very irregular periods, then we can get a scan on that basis. Obviously, the other test that we request is a semen analysis. Fortunately, in our area, we've got fairly easy access to semen analysis if the GP hasn't already requested it. Patients have to understand that the tests have to be done at the certain times and to comply with the 3-day of no sexual intercourse rule before producing the semen analysis. So they're the basic tests that are done at the first appointment. The second appointment is normally 10 to 12 weeks later. At this point, we will discuss the results that have come through. At this point, the patient, if they're eligible, may be referred on for assisted reproduction or IVF or ICSI at one of the hospitals on the Welsh contract. For our area in North Wales, that tends to be Liverpool Women's Hospital or Shrewsbury. There is another test which can be very beneficial, which is the test of the tubes. This is called a hysterosalpingogram, or a HSG, or a SALP. Basically, this is a process where, similar to a smear, a little bit of dye is introduced into the neck of the womb and pushed through, and then the X-ray people will take a series of X-rays and watch them back, and hopefully they will see the tubes being filled with dye and flow right into back into the pelvis. This is beneficial not only if people have had a past history of pelvic inflammatory disease or surgery. We know that the fallopian tubes are very, very narrow, and not only could it be blocked by scarring, but there could be little bits of debris or mucus in there, and this test seems to be effective at flushing those out. It is known that several ladies do get pregnant following the HSG because it gives you sort of a steam clean. During the consultation, we also take a very detailed history. This may seem very intrusive because we're asking about your sex lives. We ask about how often you have sex, whether there's any pain during sex, and also whether there's any bleeding after sex. The reason we're asking these questions is not because we're being nosy, but to establish whether there could be any physical cause for you not getting pregnant. If there's any pain during sex, it could be that there's an ovarian cyst, it could be that there's some scarring in there, it could be endometriosis. Bleeding after sex may indicate that there's a slight abnormality in the lining of the womb, such as a polyp or small fibroids. So we're really not asking because we're nosy. For the men, explaining a semen analysis is very important. Sometimes they've been told they've got a low sperm count. Sometimes they've been told that the sperm aren't running fast enough. And it's very important to go through all your lifestyle habits to see if there's anything that could possibly be adjusted to maybe help with this. We know that there are a wide range of supplements available on the market. Certain ones have been shown to assist in sperm production, such as zinc and selenium with vitamins A, C, and E. So it could be beneficial. The other part of the consultation is to ensure that the ladies are taking folic acid. Folic acid is now known to prevent neural tube defects, so spina bifida or any formation of the spine. This should be taken for at least 12 weeks before you actually get pregnant for it to be effective. It's no point saying, oh, well, I'll take it when I'm pregnant, because that doesn't work. So that is another part of the consultation. During the history, we'll also be asking if you're taking any medication, because certain medications are not good in early pregnancies. Certainly ones used for common conditions such as acne and certain allergies. I think Alice wanted me to mention Clomid. Clomid, the rules have changed according to NICE guidelines, and this is not recommended for women who have regular periods. Obviously, before taking Clomid, which is a fertility drug, it increases, it stimulates the ovaries to produce more eggs. We need to know that your tubes were clear and the sperm count is adequate. The other important issue with Clomid is that it does need monitoring by pelvic ultrasound scan. This is to ensure that we don't result in a multiple pregnancy. If you get pregnant after such a long wait, every pregnancy is precious, but pregnancies resulting from fertility intervention are so precious that we don't want you to have more than one. So it's important that we monitor how many eggs you're developing whilst you're taking Clomid. The main issues that we find with Clomid are the side effects. While you're taking Clomid, you take it between day 2 and day 6 of your cycle. Whilst you're taking it, you probably won't have any side effects. The side effects hit about 3 days after you stop taking it because it reacts by withdrawal. So as it's withdrawing from your body, as the levels are going down, that is when the side effects happen. Some ladies just find they have mild mood swings. Some ladies find they do have hot flushes. They feel bloated. Some ladies experience headaches and nausea. Unfortunately, in some ladies, it can respond in quite severe mood swings, either quite bad rages or feeling very, very weepy. And this makes day-to-day life extremely difficult. It is not a walk in the park, Clomid. I think everyone says, oh, my GP says you might give me some Clomid. It's not quite that simple. And if we're going to give you Clomid, we need to know that everything is at an optimal level before you have that. So clear tubes, good sperm count, and access to scanning. Did you want me to say anything else?
No, I think that was amazing. Thank you, Karen. That's so good. There'll be lots of opportunity at the end of this for questions. So if you have any questions, just make a note of them. We can get to them at the end. We'll pass over to Ariana now, if that's okay. I think, Emma, you're going to share Ariana's presentation, yeah? So thank you. Okay, I'm putting myself back on mute.
Hi, good morning. My name is Arianna D'Angelo. I'm consultant working in the Wales Fertility Institute. We are the provider for IVF in ICSI treatment, so fertility treatment in South East and Southwest Wales. So I would like to thanks actually the Alice and Fertility Network UK to give me this opportunity to share the fertility journey with you, and I would like to thank you all for listening as well. So if we can start with a presentation, I'm just gonna go through the different steps of the IVF. So next. First of all, I would like to point the attention to the fact that our work is a teamwork. So sometimes I see patients asking me, oh, are you going to be the only one involved in my treatment? And I appreciate that patients are really worried and really stressed and they want a point of contact. But it's very important for everyone to understand that we work as a team. So all of us are involved at different stages of this fertility journey, and each team is as important as the others, because if one of these teams fails, this is where actually things can go wrong, and when the patient's experience can be actually affected. So the admin team, for example, is the first point of contact. They are the one who gets the referral that Karen was mentioning when patients travels from secondary care to tertiary care. So from hospitals like the one where Karen works to us. That's very important that the admin team is reached on, get a referral and action the referral in the right way. The medical team and the nursing team are involved obviously in the very first consultation with the patients in what we call triage, where we assess the patient's body mass index, and also we assess the fact if they smoke or no smoke, if they fulfill the criteria for access IVF treatment on the NHS. The first consultation is very important. As Karen mentioned, is quite actually challenging because we're going to ask a few questions to the patients, and we also have to kind of reach a diagnosis and explain the options of treatment to them. And some of these options are quite demanding, not just physically from their body, but actually mentally and emotionally. And that is where we already need our patients to be supported by their family and friends network. We offer lots of support because we understand in IVF that this journey is not a walk in the park, and each step of the journey is supported by our counseling service. All our patients know that they can access counseling anytime, before the treatment, during the treatment, and after the treatment, anytime they want. And our counselors work independently from us, so they have their own notes where we don't access to their information. So it's very confidential and is very strongly developed in a way. The Human Fertilization and Embryology Authority, the HFEA, is fully supportive of counseling, and every patient really should have counseling or be aware that this possibility is there for them. Finally, but not least important, is the managers. We are an IVF, an NHS service, and we are managed by the NHS, obviously, the clinical governance. So we have to we have managers, and sometimes the financial implications of treatment, or the criteria or complaints or difficulties that patients can embark during the treatment are actually dealt at managerial level. But the managers are also there for ensuring that we follow processes, and that the process is safe for the patients and is safe for us as well. So it's very important that we all work together in a good team. Next. So what are the treatments that we offer our patients? When our patients reach us, most of them already have a diagnosis. So we know that they will need what we call the high-tech treatment. And these high-tech treatments are mainly the IVF treatment or ICSI treatment. They very similar treatments. They both involved having to take in drugs and having to have the creation of the baby, of the embryo, outside your body. So it's very artificial and very high-tech, as I said. The in vitro fertilization has been developed for many years. The first IVF baby now is 42 years old. So there've been lots of data around, but basically what it means, we have to stimulate the ovaries to produce some eggs, and the eggs are contained in what we call follicles. The follicles are like kind of some balloon structures. So in order to stimulate the egg growth, we have to ask our patients to inject for a certain period of time. And it takes around 10-15 days of injections to actually reach the point of having some mature eggs. So time is very important, and that is the period of time where patients can experience lots of distress, and they are basically completely in the hand of the hormones. I will explain the side effects more in details in the next slides, but just to give you an overview of what happened next, when the follicles are big and we expect that the eggs are mature, we will then go to step number 2, which is aspiration of ovocytes. And this is the first surgical procedure that our women, our patients have to undergo to get the eggs out. And again, I will explain that in details. Once the eggs are taken out, we will ask the male partner to produce the sperm, and we will then put the sperm and the eggs together in a dish, in a laboratory dish, or in the test tube, and we leave them together to interact for 24 hours so that the sperm can actually get inside the egg. And that is called IVF, in vitro fertilization. If the sperm is not strong enough, or there is not enough sperm to get inside the egg spontaneously, naturally, then what we do in the lab is we select the best sperm, what we call the best looking sperm, the one that is healthy, and we inject it inside the egg. And that is called intracytoplasmic sperm injection, or ICSI. So that is the main difference between IVF and ICSI. in IVF, there is still an element of natural conception in a way, because the sperm itself selects itself to get inside the egg, whereas with ICSI, everything is actually very much done by us, by the human factor. So we select the sperm and we inject it inside the egg. Once we check those eggs after 24 hours, we realize that those eggs have fertilized and they start to develop into embryo. So they will start dividing and dividing. Each of these cells is can, if taken out, can actually give another life. So they are amazing structures. The embryos are they are totipotent, we say. They can actually go in any direction. And they develop. We keep them in culture for up to 5 days. That is the latest time, 5 to 6 days, the latest time we can keep them in culture. And so that we can select the best embryo that could give a chance of pregnancy. And then we transfer that embryo back to the womb, and that is the step number 6 of the picture. And this is the second surgical procedure that we actually, that our patients undergone. So after the embryo transfer takes place, then the patient has to wait for 2 weeks for the embryo to implant. And that is, again, the time where our couples might struggle. So if we progress with the next slide. If we go back to step number 1, which is the stimulation of the ovaries for the production of the eggs, there are different protocols that we can use, and also different drugs. And the reason why we have different protocols and different drugs is because women, we are all different. We are human, we're not robots. So each woman is different, and each woman might require a different approach. And even within the same woman, we see variability between the first, the second, and the third cycle. So it's not always that the woman is going to react to the drugs in the same way. So that's a very important point to keep in mind. There are 2 potential protocols that are most commonly used. The first one is called long protocol and involves what is written here, the downregulation. Now, the downregulation is a phase that is usually started at the end of the menstrual cycle. And we ask the patients to inject with these drugs that downregulate their cycle. So basically, we are putting them in menopause so that we can control the hormones from outside their body. Now, putting someone in menopause is really a nasty thing to do, because as we know, the menopause can give several side effects. And we tell our patients that they will and they might experience these side effects. So for almost 2 weeks, our patients might experience, headaches, mood swings, hot flashes, irritability, loss of memory. And that is what can be tiredness, what they can experience. But the good news is that these side effects are completely reversible. So the moment we actually start with the stimulation of the eggs, so with the hormonal stimulation, our patients will feel much better because now they have the hormones that they need. So that is just to explain how those hormones can go up and down, and that can cause distress and can be responsible for some of the reaction, perhaps, or the behavior that some of our patients have in the day-to-day life. Once we start with the stimulation of the ovaries, at the beginning it should be fine, there's not much happening, but towards the end of the stimulation, so towards day 10, day 11, our patients will start feeling heavy and bloated, and they might experience nausea and feeling generally not 100%. And the reason for that is that the ovaries will become really big, sometimes 2-3 times the normal size, and they will have several eggs forming in them. So that is, again, one of the potential problem there. After we remove the eggs and we transfer the embryo, then we will give progesterone to our patients. And the progesterone is a hormone which helps the embryo to implant. So it's like a sort of glue for the embryo. And the progesterone is also the hormone of the pregnancy. And it will give lots of, again, potential side effects like constipation, discharge, feeling bloated, bellyache, headache. So it's very important to realize that during the treatment cycle, which takes up to 6 weeks, our patients are actually going through, again, as we said before, a roller coaster of hormonal waves, and that can actually reflect on these potential effects, side effects that they experience. Besides the fact that all the injections are subcutaneous, and there are some protocols which involves injecting more than once a day, so it becomes quite demanding treatment. It's not just taking a tablets and you go to work. You have to stop several times during your day, inject yourself, insert suppositories, and everything has to be well timed because the hormones have a time in our body. So if we don't follow the time, the right time, we might cause actually problems with the stimulation. So it's very important the time is respected, and that can affect the day-to-day life. Next, please. The ultrasound scan is the investigations, but also the tool that we use during the monitoring of the IVF treatment. It's again is a very personal test, a little bit like having the smear test. I showed here the picture of the probe, which it is quite intimidating and quite scary. So even if the probe itself is only like a finger or a tampon, it does affect because it goes inside the vagina. So it is an intimate scan, and our patients have to have this scan several times during the treatment. So it's it is not the nicest treatment really to undergo. But overall, the ultrasound scan is well tolerated, and it gives us so much information. Here in the picture in the middle, you can see the picture of the ovary and where the arrow is, and the little black areas are the little follicles which contain the eggs. And on the right, you can see the picture of the womb, and the line inside is actually the endometrial cavity, which is the place where the pregnancy develops. Next. The daily injections, been through that, they are subcutaneous injections, and during the period of 10-15 days, we aim to recruit between 5 and 15 follicles. If you think that every month each woman produces only 1 follicle, 1 egg, we are actually inducing what we call superovulation. So we're making them to produce 10-15 times more the number of eggs that they would normally produce. And that is where the ovary become big, and that is when they can start experiencing all these side effects of bloatness and feeling heavy, and they sometimes can't actually fit in their own clothes. The ultrasound scan is used to monitor the response until the follicles reach around 17-20 millimeters in diameter. And the next picture, the next slide, will show you the difference between a small ovary with small follicles and a big stimulated ovary. So this is the same ovary, but where all the black area are actually the follicle that now have reached around 15-16 millimeters. And there are lots of them. You have to think that the ovary as a ball. So what we see here is only the 2 dimension of the ovaries, but actually on the back of this picture, you have more follicles because there are the ovaries in 3 dimension. It's actually literally like a ball. So they become bigger, like oranges, or sometimes even bigger, and they can be quite uncomfortable. Next. So the egg collection is the procedure where we collect the eggs. As I said, it is the first surgical procedure that the patients undergo. It is very important that before undergoing the egg collection, the patient is given an injection called also final injection, because it's the last injections they're gonna have. And this injection will make the eggs to mature. It's very important also that this trigger shot of final injection is given 36 hours in advance, because it takes around 36 to 38 hours for the eggs to mature. So again, timing is very important. Sometimes patients are, you know, usually this injection is given on a Saturday evening or Saturday night, because most of the collection happens on a Monday, and they are perhaps outside, they are with family, with friends. Some patients were in a concert once and they had to go in the toilet to inject at midnight. So it's very important to be aware that this is an additional stress, which unfortunately is necessary. It's not because we are sadists, we want them to inject at midnight or 2 o'clock in the morning, but it's just because their recollection is going to be on a Monday at 2 o'clock in the afternoon or at midday, and it takes 36 hours for the eggs to be ready and ripe. So the eggs also are collected under conscious sedation. Again, these drugs can affect, obviously, it's strong Valium, strong painkillers. The patients won't be able to take any legal decision for 24 hours. They won't be able to drive. They will be very sleepy, you know, generally not 100%. They have to be nil by mouth for 6 hours before the procedure. And as I say, they will need to be escorted and will need to have a partner or someone with them during the actual procedure. The procedure is done transvaginally. As you can see from the picture, there is still the same probe that we use for the ultrasound scan. There is an adapter on top of the probe where we pass a long needle. It's about 25-30 centimeters needles, so it's quite long, and it goes straight inside the ovary, straight inside the follicle, and that is attached to a pump which suck the eggs out. The egg then goes inside the fallopian the tube, sorry, not the fallopian tube, the actual tube, and then this tube is checked by our embryologist to see whether there is an egg inside or not. 70% of the follicles contain eggs, so the success rate of the egg collection usually is around 70%. Next. Once we have the embryo, and you can see here on the left an image of an embryo. This is a beautiful embryo, what we call the blastocyst. The blastocyst is an embryo which has been cultured for 5 days. So it does have already the aspect of a small pregnancy, actually. You can see all the cluster of cells, and that is what we call inner mass cells, and that will develop into the baby. And then you can see all around the cavity with some fluid, and that will become the fluid nurturing the baby. So this embryo is quite a robust embryo, and it's got almost 1 in 2 chances to implant. So how do we put the embryo back? We do it again as a small surgical procedure. It's very similar to having a smear test. So we use this instrument on the right, this plastic instrument called a speculum. And the speculum is inserted in the vagina to expose the neck of the womb. And then we pass a little cannula through the neck of the womb, inside the womb, and then gently inject the embryo, which is very delicate, up to the top of the womb. This is all done under ultrasound guidance. This time the ultrasound is on the belly, so we like the patients to come with a full bladder. Again, that can be quite uncomfortable. We are pushing from down, pushing from up, so it's a lot to go through. And at the same time, the patient is not in the most dignified position, which is, you know, the gynecological position. So, but our patients are really good. and they go through a lot, and their target is to get pregnant, but they really need support in that. So once the embryo transfer is done, then we give them some suppositories of progesterone, as I said, to help the implantation of the embryo, and then we leave them for 2 weeks. So that is the time when they feel a little bit more vulnerable, because everything stopped all in once, and they still have lots of hormonal turnaround or turnover inside. And then we hear from them after 2 weeks with the results of the pregnancy test. So next slide. There are some risks associated to IVF. The most dangerous risk is the ovarian hyperstimulation syndrome, and I would like to spend a few minutes on this, because this can be actually life-threatening. There have been some people who have died actually for ovarian hyperstimulation syndrome. Likely there are many protocols and many ways we can prevent the syndrome from occurring, but occasionally, again, as I said, each woman is different, so occasionally these things happen. You can see the image of the ovary. This time you can see yourself, if you remember the image that I showed you before, these ovaries full, packed with follicles. So these patients got ovarian hyperstimulation syndrome. She has reacted too much to the drugs, and she has produced, instead of 10, 15 follicles, she has produced 40, 50 follicles. This can be very, very uncomfortable for the patients. The ovaries become literally like watermelons. They can go up to 10, 15 centimeters inside the body, and there is a risk of rupture, risk of torsion. The patients get dehydrated, they can't eat and drink, and in the worst scenario they need to be admitted in the hospital to have some help in terms of drugs like anti-sickness, blood thinner. So it is very important that we avoid the ovarian hyperstimulation. That occurs between 1% and 3% of our cases. On the other end, we have the other end of the spectrum is when the patient doesn't respond to the stimulation. That is called poor response, and that happens sometimes when there is a low egg reserve or in advanced age. Sometimes we don't get it right. We give a dose of drugs to a patient and it's not the right drugs. And again, as I said, we all human, so we can stop and start again. There could be side effects of the sedation, like allergies, or side effects of the surgical procedure, like damage the internal organs. Failed fertilization is another potential risk associated to the IVF and ICSI treatment. This occurs when, despite we put the eggs and the sperm together in the dish, they don't seem to be interested in each other, so the sperm doesn't get inside the egg. And at the end of the 24 hours, we end up with no embryos. This occurs in 5 to 7% of the cases. It can be very, very frustrating and very upsetting for us and for the patient. Sometimes the embryo stops growing in the lab during this 5 days journey for the embryo. Sometimes things go wrong and they stop growing. Again, that can be really very, very upsetting. Finally, multiple pregnancies, miscarriages, ectopic, these are all potential complications that can happen subsequently to the embryo transfer. The ectopic in particular is life-threatening, and it's very important that it is picked very early. So once the patients ring us with a pregnancy test, with a positive pregnancy test, we usually provide a very early pregnancy scan just to make sure that everything is fine before discharging her to antenatal care. We have now a new threat to us. This is the COVID-19. Obviously, the patients will be asked to attend a hospital environment on several occasions, and there is a risk to catch COVID in the hospital. So we are very clear with our patients that they have to kind of take this risk together with us if they want to go ahead with the treatment. But this is another burden, another fear, another worry on top of all what the patients, our couples are going through. And finally is the treatment failure, when they, after the 2 weeks, the treatment is negative and they have to start everything all over again. So, but I will leave obviously the next speaker to discuss that part. So I think my last slide is, I've got my last slide, yeah, it's a thank you slide. I'm just put my social media link for everyone who wants to follow me or get in touch with me. Many thanks for listening.
Thank you so much, Arianna. That was so much information and really thorough. Thank you. We're going to pass on lastly, but no means leastly, to our Emma. Emma is our project worker in South Wales, and she's going to be talking now all about the emotional impact and how it affects people's mental health. Okay, Em?
Yes, just bear with me. Okay. Can you hear me? Yeah, okay, that's great. Okay, thank you. Thank you so much, Alice. And thank you, Arianna and Karen. I really hope that, you know, you've all picked up, you know, a lot of information there, you know, in terms of the physical and the medical side. And so, which is why I'm here today to talk to you, you know, about the emotional impact, you know, and what you know the patients will go through, what your loved ones are going through. Yeah, I'm going to talk about that impact. I'm going to talk about some triggers, you know, and just everyday you know, things that they struggle with, and like things like social gatherings. I'm going to have a chat to you as well about what not to say and how to help. But before I do that, I really want to talk to you just very quickly about why we're here and what you know, family and friends have told us, and as to why, you know, we've designed this event today. And I'm going to tell you two case studies that some friends and a family member, a sister of those going through IVF, have shared with us. And then I'm going to tell you about what family and friends, you know, are telling us. So I'm going to read something for you just very quickly. And this first one is from a sister of a lady who was going through multiple rounds of IVF and pregnancy loss. And this is what she said: "This wasn't the plan. This wasn't how it was supposed to happen. I was the younger sister. I was supposed to be the first auntie, and I wasn't supposed to have the first grandchild and break my sister's heart. After my wedding, I was ready for children, but my sister and husband had been trying for 4 years by this point and were about to have IVF. So how could I do that to them? So I waited, and I told her that I wasn't ready. I could see that relief on her face, but I was ready. But my sister meant more to me, so I waited. I couldn't break her any further. I couldn't see her heartache. I could see, her heartache every time someone announced a pregnancy, and I just couldn't be another reason for her pain. Eventually, I had to begin trying for a family because I was getting older and I was worried for my own fertility. Telling my sister that I was trying was one of the hardest conversations I've ever had. It made me feel sick, and I could see that I'd hurt her deeply. But it also made me feel sad because I know that nobody in my family wanted me to try for a baby, and I felt like I was letting everyone down. I couldn't discuss anything pregnancy related with my sister because I had so much I wanted to share with her, but I kept it to myself. I felt like I had lost my best friend and I had no one to talk to because I wanted to celebrate with her, but I couldn't rub that joy in her face because her pain was so huge. It was a difficult time for our whole family, and nobody knew how to deal with it or what to say or how to support my sister. Should I have been more open about how I was feeling in those early days? Would that have helped her and me and my family? When we finally began to talk about it, it really did help. I wish I had had the courage to speak openly sooner. And I wish I'd had someone to talk to give me some advice about how best to support and to deal with the situation. And I felt this was, so I felt this was a really important case study to talk about, because pregnancy within families and friendship circles is so incredibly difficult, and the pain that we see our service users, our patients go through and dealing with this is huge. And as we know from this case study, it has an impact on the whole family. So I think, you know, just to maybe some advice is to possibly think about pregnancy announcements. So, you know, if you do decide, you know, that you want to start trying for a baby, because absolutely, you know, you should do that. But maybe tell your loved one privately and sensitively, and give them that time and warning, because what we know is that being provided with warnings, with being told privately. Sometimes people say they prefer to see it in a text, because it means that they can take the time out to cry, because they will, you know, this is so huge for them, you know, so they can go away and sort of mentally prepare and sort of get to grips, you know, with that situation, with that new situation and what they're faced with. I mean, if you can do that, that, you know, that is, you know, that would be really great. So the second case study is from a friend, and of a lady who was going through IVF, and this is what she said. I wasn't sure what to say for the best. Should I ask how she was feeling, or would she hate that? But if I didn't ask, would she think that I didn't care? Should I talk about my kids, or was that best avoided? If I do talk about them, should I not say anything too positive? Because I don't want her to feel bad. But will she know I'm doing that? If I don't mention them, will she think that I think that she's not interested in them? It is so difficult, because you know that your friend is in pain, and you know that they are putting on a brave face. I don't think that my friend would have wanted me to ask how she was doing. If she was putting on a brave face, it's because she wanted people to think that she was okay. So I didn't want her to know that I thought that she wasn't. She was a very proud person, and at that point had spoken very little about their struggles with fertility treatment. But after a few years of treatment, she did start to open up about it. And with it, I grew in confidence. I began to understand an element of what she was going through and how she was feeling. And this made it so much easier to know what to say. And it really helped our relationship and my ability to be able to support her. So those are just two sort of case studies, really, for extracts from real people who have struggled and gone through this. And I think, you know, ultimately, you know, what comes out of that is that openness, communication and honesty is absolutely, you know, the best way forward. And, you know, you're not always going to know what to say, and that is okay. That is okay. But being open and honest about that and ready to listen, I think, is key. And of course, learning, which is what we're all here for today. So what you've told us, you know, we are told by family and friends that you feel panic, you feel a sense of desperation to fix the problem for your loved one. You're telling us that you feel incredible pain at seeing them hurt, powerless, and a sense of sort of loss of control. And a struggle to understand the medical treatment. And I really hope that the fantastic presentations this morning, you know, have helped you to understand that a bit better. You know, you're telling us that you don't know what to say or how to support, and extreme worry for your loved one's health, physically and emotionally, you know, and anger and jealousy. And I would like to say to you all that these feelings are completely normal. It's absolutely normal, and you know, you are not alone, you know, in how you are feeling, and we are here to support you too. So ask us any questions at any time. You know, you have my sort of details and my information. So now I'm going to tell you a little bit about that emotional impact on how your loved one, you know, will be feeling and what they're going through. Because, you know, IVF, fertility treatment, investigations, it really does. It takes over every aspect of your life, you know, relationships, work, financial, social. You know, lots of people this morning have touched on, you know, that emotional roller coaster. And you know, a lot of people tell us that, you know, they struggle, you know, with constant questions, you know, about how it's going and how they're feeling, because, you know, on days, you know, when you're feeling particularly low, I think those questions are really difficult, but many like to be really open about it. But I think it needs to be on their terms, because some days you feel great and you want to talk about it because you're feeling good, and other days it's just too much of a struggle. So I think that's something to really bear in mind. That doesn't mean to stop asking though, because please just let them know that you're there for them and you are ready to listen whenever they feel ready to talk. So our service users, you know, they're telling us, you know, they feel shame, you know, and anger and frustration. Why me? This is so unfair. You just see people going through and getting pregnant so easily and having families, you know, so easily. You see pregnant and families everywhere, you know, and it's really difficult to understand why this is happening to them, and it does feel incredibly, you know, unfair, and it does turn into an obsession. There's constant Googling. You think about it 24/7, and that's not just when you're going through treatment. That's 24/7 from the day you decide, you know, that you want to have a baby, and certainly from the day that you find out that you've got fertility issues and that you're going to have treatment. The fear is immense. It is, you are frightened of so many things, of it not working, of potentially a life, you know, without children. You know, it's, we could have a whole webinar on the fear, you know, that people feel during a cycle, and I'm sure that's something that we will touch on in future sessions. The guilt, again, Lisa's story video this morning, I think portrayed that really, really well. The guilt that you feel, you know, towards, you know, your parents. You know, you feel, you know, they deserve to be grandparents, and you feel like you're failing them because, you know, you haven't provided them with that grandchild yet. You feel guilty when you feel that you have to withdraw from spending time, you know, with nieces and nephews or children of close friends. You know, the guilt, there's all of these feelings, you know, that are surging through you day in, day out, and that you're having to deal with. And the isolation, you feel isolated constantly. Isolated because no one understands. You know, unless you've been through it yourself, it's very difficult to understand exactly what you go through. And isolated because you have this feeling of just being left behind. You sit around the kitchen table with your friends, you have maybe a glass of wine or dinner, you know, with friends, and they're talking about their children and, you know, prices of nappies and feeding schedules, and you feel left out. And that isolation is so incredible and painful. And, you know, something I just wanted to end this slide with is that you just become really accomplished at saying, I'm fine, when I'm not, when you're not. And, you know, that's really a difficult thing, to smile every day and pretend every day that you're okay when you're going through such immense pain. So the next thing I want to talk to you about is triggers, and again, that could potentially be you know, a whole webinar, you know, on its own, because when you are struggling, you know, with fertility, there are triggers everywhere you look. And I've already talked to you following the case study about pregnancy announcements. You know, your social media feeds are full of pregnancy announcements. You know, you've got family and friends, you know, moving on and becoming, you know, parents, you know, on almost, you know, a weekly basis. You know, there are constant pregnancy announcements out there, and they really do have one of the biggest impacts, you know, on your emotional well-being when you're struggling, you know, with fertility. So like I said earlier on, you know, if at all possible, you know, to give somebody a warning, a private sensitive warning of that you might be trying, or that you are pregnant, to allow them to mentally prepare and to take and absorb that in, we are told, you know, really does support people. For a lot of people, you know, and everybody, I think what's important here is that everybody's different. So for some people, pregnancies, to see somebody pregnant is just too much to bear, and it is a hugely difficult sight. So even going for a walk and seeing a pregnant lady out in the shops, you know, it's an incredibly difficult sort of thing to see. But for others, it's babies, you know. So I think the key thing, you know, to bear in mind here, that everybody is different. Triggers, again, you know, Christmas and Mother's Day, Father's Day, these are huge triggers that the people have to mentally prepare for months in advance. You know, before these big calendar events, because they are so painful. And again, it goes back to social media and, you know, all of the photos of, you know, happy children and pictures of, you know, happy Mother's Day, you know, mummy, and you're the best in the world. You know, those are they're just too much to bear. And a lot of people find that they have to come off social media just to be able to cope, you know, with those big calendar events. And simple things we find, like writing Christmas cards or birthday cards. You know, when you're writing to multiple people, you know, families, and you have to sign that card, you know, from yourself, your partner, you know, and maybe your dog, you know, or your fish. You know, it's difficult. It's just constant reminders of what's not happening for you, and it's not fair. Shopping, just simply walking past that baby aisle is horrendous and a massive trigger for so many people. Baby shops, seeing people out pushing their buggies in the high street. And something that I want to mention especially is going out for lunch, maybe with friends or family. You could walk into that coffee shop, incredibly happy and excited about your lunch date with friends, and you might see somebody in the corner heavily pregnant or with a newborn, or even a party celebrating a baby shower, and your emotional, your mental health will plummet there and then, and that's it. And your friends, you know, they might wonder what on earth has happened, what have we done? But it's nothing that you've done. You know, it's what your friend, your daughter, your son has seen in the corner of the room that has provided them with this massive trigger. And sometimes they're going to have an exit strategy. A lot of people go into all social gatherings, which I'll talk about later, with exit strategies in case those things happen. You know, adverts and TV all day, every day, there are adverts and TV programs with babies, pregnancies, children, parenthood. You know, you just can't get away from it. And something that we're being told a lot of these days is when a partner, you know, has a child from a previous relationship. That is a massively difficult dynamic and complex thing to deal with. You know, you're watching that child reach milestones, you're hearing people discuss, you know, who he or she might look like, and you know, you're watching those special moments between your partner, you know, and their child, you know, but you're constantly reminded that you haven't got your own sort of biological child, and it is so hard, it is so difficult, and the guilt that they feel in relation to those feelings that they may feel are equally massive. So, you know, if you do find yourself in that situation, please bear this in mind, because that's something that your loved one is battling, and I really mean battling with, on a daily basis. So social gatherings, social gatherings are so difficult. Baby showers, weddings and christenings, you know, they're the obvious ones. You know, simple things like going to a wedding, you know, and seeing your you know, great aunts, you know, cooing over the latest you know, addition to the family, or some people like to wait for these big events to announce their own big announcements, and so these are really difficult. But general gatherings, you know, barbecues, where the whole family come together, you know, and birthday parties, they are so hard. And work events, because of course your colleagues all have mostly have children, you know, and this fear, you know, you worry for months and months and months on end leading to these big events, and about the fear of these difficult questions, you know, more pregnancy announcements, like I said, seeing family members or aunts, you know, cooing, you know, over sort of newest arrivals. And I think it's something to be made aware of, is that those who are struggling with fertility, before they go into these events, they are preparing themselves. They are sort of mentally designing coping mechanisms that can get them through every single one of those events. And they are also thinking about exit strategies. So I think my advice, you know, to you is that have an understanding that these are really difficult, that your loved one is constantly anxious about saying no to social gatherings and worrying about what people might say. And if you could have an understanding about declined invitations, or even better, give people the option to opt out, you know, that is going to be massive for them. You know, they know that they don't have to go, because they really do worry about what you might think and hurting your feelings about not going to that big event. If I don't go to my best friend's baby shower, you know, is she going to hate me for the rest of my life? Is our relationship gonna crumble because I didn't go there and I wasn't able to be there for her? If you can have that understanding of what they're going through, that, I believe you me, will be massive for your loved one. So again, what not to say. This is really very much a whistle-stop tour of what not to say, because there's so much, you know, out there. And what I want to say here is that, you know, there is an understanding that a lot of the time, what is said, it's known that it comes from a good place. But, you know, going back to what we've talked about in relation to, you know, when you haven't been through fertility struggles, and it's very difficult to understand, you know, how they feel and what to say for the best. So I really hope that a few of these, you know, will help you to understand that a little bit more. And the big one is, do you have children, or when are you having children? Do you know, it seems like the most natural question in the world, but to somebody struggling with fertility, it's honestly the most painful. And asking these questions adds heaps of pressure onto couples who may not even feel ready to talk. And often then these feelings result in feelings of embarrassment and shame. You know, the next one, have you tried? You know, there's so much information out there on the internet, and you know, it's so great that you know, family and friends, you know, are keen to look into ways that have helped other people in the past. So have you tried eating an avocado, some goji berries and 5 Brazil nuts every day? You know, we've heard that so-and-so in New Zealand, that worked for them, and now they have 3 children as a result. You know, your loved one, they are different, and not, and also, by the way, they have tried all of those things. I can almost guarantee you that every single thing that you found out on the internet, they've already tried, and are probably still desperately trying. So I doubt very much whether there is anything online that your loved one hasn't yet tried. But ultimately, everybody is different, and what worked for somebody else isn't necessarily going to work for others. Be positive. That's a really difficult one, and again, it comes from a really good place, but being told to be positive just makes you feel so much worse, because I can't help feeling negative, you know. And negativity actually is nearly always a coping mechanism for preparing yourself for the worst. lessen the fall, if you like, because you have to mentally prepare for your cycle not working, because if it doesn't work, you are going to be devastated. So you need to prepare your mind in preparation for that. So yes, there does become an element of negativity, but that is a coping mechanism. And saying be positive really does make you feel like you're failing, even more than you already feel like you are. The stop stressing, it will happen. It's yeah, you aren't stressed when you start trying for a baby, are you? Nobody's stressed when they start trying for a baby, yet, they still found themselves in the situation, where they couldn't get pregnant and they were struggling, with fertility. And after so long and so much treatment, how on earth can you not be stressed? And I think it's a really difficult one. That there's two here that are particularly difficult, and you can borrow mine. That's something that I think making light of how awful and how hard maybe your children are, just doesn't help. And I think it just downplays their emotions. And my husband only has to look at me and I'm pregnant is something that people have to hear so often. And it's one of the most difficult things to have to hear. And finally, maybe it's just not meant to be. And nobody who are going through fertility treatment wants to hear maybe it's not meant to be, because they do need to try their very best to remain hopeful that this is going to work and it is going to happen for them. So finally, how can you help? Well, firstly, you're all here today, and so you've taken that first step to help your loved ones. And I just want to say a huge well done, and thank you on behalf of your loved ones for doing that, because it's just incredible, and it just shows the huge love that you have for your sons, your daughters, your friends, and we're thrilled that you're here. So but learn, how can you help? By doing what you're doing here today, you are learning more about the process, about what they go through, and that will be able to help you to understand a little bit better, and therefore be able to support them better. I think an understanding that everybody's journey is different, going back to have you tried sort of X, Y and Z. I think every single person, their journey is different. They feel differently about it. They deal with their emotions differently. Some people are want to be very open and want to talk about it, but other people really need to keep it private, and all of those things are okay. And I think just respecting and understanding that their decisions and their journey and how they deal with it is really, really important. The third thing is find support. You're here, so you've now met us all, Fertility Network UK, we're here for you too. So you can email me, Alice, Liz, any member of the team at any point in time to ask us any questions. And we are going to be putting on more groups like this. So I'm really keen to hear, what you thought of today, and what you'd like to know more about, in the future, so that we can tailor make these groups, for you in the future. And there's also social media, and Instagram. There are lots of people on there, and you can follow people who are going through this on a daily basis. And a lot of people tell us that they find that a really good learning curve that provides them with a natural daily sort of understanding. But remember, yes, us here, we are here for you. The fourth thing is to listen and be honest, because we know that you can't always know what to say, because when you've not been through it, it is very difficult sometimes to know what the best thing or the right thing is to say. But if you are honest with your loved one, you know, about that and say, look, I just don't know what to say, but I'm here for you and I'm ready to listen, that I promise will be a huge, huge support, you know, for your loved one, knowing that you are there whenever they feel ready, and the need to talk to you will be the biggest support, you know, that you can possibly offer. And then finally, it's acceptance and acknowledgement. So acceptance, you know, try to learn, you know, to accept that your loved one is struggling with this, because it is a difficult thing. You are going to struggle with the fact that your loved one is on this painful and traumatic journey. And so if you can try to sort of accept that this is a very difficult time for them, and even though you may not be able to relate that well, you know, try to understand that this is something that is happening to them, and maybe try to be sensitive about them being, they're going to be a bit more antisocial, if you like, you know, and they're going to behave differently to how they normally behave. And be sensitive, you know, about that, and understanding, you know, like I said, you know, about those social gatherings and declined invitations. So ultimately, you know, what I'm saying is that you don't need to be an expert in fertility to support someone struggling. Your friend, your sister, daughter, son, you know, they know that you haven't experienced fertility issues or loss. You know, so they don't expect you to be able to fully understand their pain. But what you can do is support them and be there for them. Be honest when you don't know what to say, but just offer to listen. And that alone is worth a million stories of hope and words of advice. So, okay, excuse me, my last slide isn't coming. Oh, there we go. Okay, so finally, you know, like I said, we're here to help. Okay, we are going to be setting up a future support group. I'm really keen to hear about how you feel today went, what you'd like to learn and know more about in the future, and we will do that for you. You've got my email address, so please email me at any point in time. We have got a support line. The number is up here on the screen, and also Diane runs the support line. She is an ex-fertility nurse, and you know, she is just wonderful and can offer all sorts of support into and advice and guidance. And on the information line as well. Look, we're here to support you too. Okay, so don't struggle alone, and please let us know what we can do to support you. I really hope that this presentation, a very quick one in relation to the emotional impacts, but I really hope that it's given you a better sort of insight today into what your loved ones are going through. And thank you very much for listening. Alice, I think I'm done.
Oh, thank you so much, Emma. That was quite hard to listen to. I'm sorry if anybody found that upsetting. I find it upsetting to listen to, but again, it's why we're here today, is to really get an understanding of IVF is not a given, it's not a lifestyle choice, it's not easy, it's full of ups and downs, it doesn't work so much of the time, and it's hard. So thank you so much to everybody. We're now going to have some time for some questions. Please ask any question you want. No question is the wrong question. If you don't want to, that's fine as well. But please, if anybody's got any questions, you can either type it in the chat box or you can unmute yourself and ask. And we'll try and answer you. Any on the chat, Em?
No, there isn't. But we did have a question for Ariana. It's actually more in relation to treatment. So it's come from somebody, and their question is about, they've had 2 cycles cancelled because of overstimulation, and they're worried that you know, do you think, well, do you have any advice really for them going forward in terms of why, you know, that might be happening and what they could do differently?
Yes, yeah, thanks for the question. It's very useful, actually. A very useful question. I think if you had been cancelled, that means that obviously the risk was extremely high. Usually there is a protocol that can be given to avoid cancellation, and this protocol, I didn't explain that during the slide because the time constraint, but this protocol is called antagonist protocol, and it's quite short, and it does put any less burden on the ovaries. The only thing would be to freeze the embryos if you are over responding again, and then allow time for the ovaries to go back to normal, maybe 4 or 6 weeks, so that then the embryos can be transferred without the risk of hyperstimulation. So this is something that can be considered as a future strategy.
Thank you so much for that. I hope that answered your question. Okay, let's have a little look in the chat box to see what we've got here. Okay, right. This is the question. So this has been really helpful. Thank you so much, and I relate to it so much. I'm going through IVF at the moment and supporting friends going through it. One of my friends has only 1 cycle left, and I don't know how much to share with her about my latest cycle, as I don't want to upset her. What's the best way for me to support her? We used to share everything, but I have started not to share as much, as I think she finds it painful sometimes. Oh gosh, that is really difficult, and I think Alice, you may want to come in here at some point as well, because I know that we've chatted about this a lot lately, but that is an incredibly difficult situation to be in, and I think that ultimately honesty is nearly always the best way forward, because I think, when you are honest, it's very difficult. I think sometimes people, if you hide things, I think ultimately what we're told, is that that's more painful, rather than, it's going to be painful for your friend, whatever, being honest and open about it or hiding it. And I think ultimately that the openness and honesty, where possible, and I know how hard that is, I really do, and I'm sorry that you're going through that. But I would ultimately say that probably the best way, is honesty, and ask her what she thinks. Just say that this is the situation that we're finding ourselves in. I'd really like to know how you feel about this, and what would you like to see in terms of how best that we can support each other. Alice, I don't know, did you want to add anything, to that?
No, I think you've covered it there, Emma. I think, yeah, it's just important to sit down with somebody and say, listen, this is really hard. Exactly what Emma said, this is really hard. Let me know what you need. I don't want to upset you. And just be not afraid to say that somebody's struggling and that you are there for them, no matter what the situation, really. A few more questions coming in, actually.
Yeah, we have. Alice,
let's have a look. I'll do one. Okay. I found this very helpful, thank you. Would you be able to offer any advice for my husband to support his friend? As he asked me what he should say, and I feel it's a bit different for him and a male perspective. Well, yeah, I mean, it can be slightly different. I think we see, it's pretty obvious, men can find it much harder to speak to their peers and to ask for support. It's been reported that, men found it really hard with the pandemic because they felt really kind of helpless and sidelined. Often we hear from men that during kind of the medical appointments, they feel like a bit like a spare part. Even if it's a male factor issue, it's the female that has to go through most of the assisted fertility treatment. It's the female who Ariana said has to lie with her legs open and feeling a bit self-conscious, very self-conscious and uncomfortable. And so often it's really difficult for the men because they feel useless. They can't take any of it off her. It might be a male factor and they feel guilty that she's got to go through all this. and he can't do it for her, that he has to feel like the rock and he can't show his emotions because he has to be the strong one. Society as well, you know, it's a real, we have a real problem in society with talking about sex, periods, fertility, infertility. It's still kind of quite taboo, which baffles me because it's reproduction. It's the most obvious thing to talk about, but people do struggle with it, and men can find that especially hard to kind of open up and speak to peers because of the whole masculinity. You know, if there's an issue, especially a male factor sperm issue, it makes lots of men feel like less of a man. They can't get their girlfriend or their partner pregnant. What's wrong with you? Oh my God, you know, nothing wrong with my swimmers. Oh, you know, all that. And it's banter, isn't it? Banter that lots of the men we know do, because it's kind of the way they keep themselves safe. But yeah, it's difficult. So I would say to this question, encourage your male partner to know that you shouldn't be embarrassed, because like I say, it's reproduction. It is the most basic thing. So we shouldn't be embarrassed to talk about it. And there is loads of support now for men. It is becoming much more accepted for men to open up. Fertility Network UK have groups specifically for men, where it's men only. Men can get together without feeling like they're going to upset their female partners. They won't say the wrong thing to upset her. They can say whatever they want. And if she's being a moody nightmare, they can talk to their male peers about that and say, oh my gosh, how are you coping? Because she is just driving me mad. And that is important. It's important that men have that safe space to speak. So we have that. So please put your partner in touch with us, and just be open. Be willing to say, listen, I know you're going through problems. It's hard. You can talk to me. It's exactly the same as what Emma was saying before, but we do recognise that men find it harder. It is harder for them, but the support is there. We have an amazing group which is run by a racing car driver, Toby Trice, and there's a guy who runs something called the Man Cave, really looking at mental health of men, and they're fabulous. They talk so openly about their fertility journeys, and I would really recommend that any men struggling, if you know any men, if it's your son or your brother or whoever it is, tell them, say, listen, there are men talking about this now, and it can really help. So peer support is recognised to be really, really useful with stuff like this. So male, female, whatever, peer support is key. Talk to others about how you feel. That's what I would say. Emma, anything to add on that one?
No, you've absolutely covered it, Alice. Absolutely. I can. Shall I ask the next question? Yeah, lovely. Okay, so we have recently had our treatment stopped due to a family member testing positive for COVID. We are struggling to come to terms with this break in treatment as we both tested negative. Is there any advice for dealing, with these kinds of emotions? I think maybe Alice and possibly even, Ariana to a degree. I don't know. Oh, you're on mute.
I mean, life on hold. The implications of COVID are so extreme. People feel really out of control, like they can't get on with the next step. Time is ticking, all these horrible emotions and worrying. But what we would try and say is, it's out of your hands at the minute. You can't do anything. Focus on what you can do. Be kind to each other. Look after yourself. Give yourself a break. Do things that make you feel good. And just try and look after your relationship and focus on the now. I don't know. Ariana, do you have any?
Yes, yeah. This is why I mentioned COVID briefly at the end of my presentation. This is adding so much stress and so much anxiety to the fertility journey, and but unfortunately, as you say, this is out of our hands, and we have made so many changes in our service to make it COVID proof, and following what is the law now, because we have been asked by the HFEA to follow the recommendation from Public Health Wales, obviously, in England. So this is what's happening. If someone test positive and you've been in contact with that person, even if you're negative, we can't see you for 14 days, and that is the end of the treatment for that period of time. We will try obviously to re-engage with the patient, and but I appreciate this is very stressful because some patients are in the middle of treatment, so they started the tablets, injections. It's just too much to take on board. Again, counseling is available to them if they need, you know, they feel they are struggling. But unfortunately, we have to think about the safety of all our patients and also the safety of the staff, because if we have an outbreak in the IVF unit, you know, we have to close, and that will affect all the other patients as well. So we have to be careful. I'm sorry, but this is life at the moment.
Yeah. Thank you, Ariana. And you know, for all of you, you know, who are struggling, is, you know, we do have a lot of resources on the Fertility Network UK website. In terms of coping sort of strategies, you know, coping mechanisms, you know, take a little look, you know, there's plenty on there. Or alternatively, you know, you can email me as well, you know, and I can send you some links out, you know, some mindfulness and some things that, you know, a lot of people are telling us that they are finding helpful. So we can do that for you. So just send in, you know, either myself or Alice an email, and we will be able to send that on, or just have a look at the website. Okay. Alice?
Okay, so I'm in the position where I need to lose weight to progress with my treatment, and have the best chance. I have PCOS, which is polycystic ovary syndrome, and I'm desperately trying with little support. Gynae have basically washed their hands until I lose the weight, but being told just lose weight is really hard, especially when families say, just do it and help yourself. We've been trying for 4 years now, so struggling for quite some time. Well, I just want to say to this person, you are not on your own. The number of people who come and ask for informational support from Fertility Network UK who are affected by this is a lot. You're not on your own. It is so hard to lose weight. And when someone says, just lose the weight, just make some changes. I mean, if it was that easy, we'd all be like supermodels, wouldn't we? So it's really hard. Give yourself a break. Yes, you have to. If you want NHS treatment, your BMI has to be 30 or below. And there are risks with treatment and pregnancy for people who have a higher BMI. That is fact. So of course, making changes to kind of get your weight within the healthy range is the right thing to do. But it doesn't make it easy. Starving yourself and going on crash diets, crazy diets, is not going to help. I've supported women before who've just been thrust diet pills. So they've been having diarrhea for days and days. That's not going to really help you. Sensible, balanced diet where you can. You know, we're not saying you can't have a little glass of wine now and again, or a chocolate bar. It's just about trying to make those healthy decisions. Lots and lots of fruits and vegetables, folic acid, like Karen said earlier, and making sure you're not deficient in something like vitamin D. But it's just about as healthy as you can be, being active most days. It's really hard. Karen, do you have any help? Because a lot of people who are affected by this, they kind of hit this wall at the primary care stage, or when they get to you within secondary care. Do you have any advice or information for anybody that could help?
Just developing a long-term strategy, really, because once the weight starts to come off, it's got to stay off. And as you say, the quick fix, that's just not going to do it. I always sort of say, look at some sort of lifestyle that you can maintain over time, that you're not going to feel hungry, that you're not going to be tempted to cheat. You just need something. Look at what your lifestyle is at the moment and see whether you can introduce something like Slimming World into that, because Slimming World is little and often, which sometimes makes sure that you're not hungry. The other thing I would say is maybe look on the Fertility website, which is for ladies with PCO, because they've got some quite good tips on there as well for people who've been really struggling, and it is so hard. It's the most important things ladies with PCO can do. It's the most effective way of restarting their cycle by losing the weight, but it's the hardest thing in the world. It's dreadful, and people get so desperate that they're hitting the shakes diets and all these. That is not a long-term strategy and may in fact be harmful to your health in the long term. Certainly if somebody comes to me with a higher BMI than is acceptable to be referred for treatment, then I do tend to keep them on the books to try and give them some support and point them in the right direction. But I understand a lot of practitioners won't do that. But good luck. I hope you find something that suits your lifestyle.
Thank you, Karen. I mean, yeah, I mean, there's, again, going back to this, you know, there's so much support, like for peer support is really important. And the same goes for weight loss. You know, if you're trying to do it, you're going to have more success if you do it with somebody else. Really, that group support can be really helpful for weight loss as well. But also, you know, if you're living with somebody, get them on board. You can't be expected to lose weight by yourself. Get your partner to do it with you. And if your family are putting on pressure and saying things like, just do it and help yourself, well, turn it around and say, can you help me? Be supportive. When I come over, don't offer me a cake with my cup of tea. You know, like, they need to know that it's not easy. And all of us here probably have tried to lose some weight, and we know how hard it is. And when you're stressed and you're going through treatment and you're waiting for results, I'm the first person to put my hand in the biscuit tin. I'm sorry, it's stressful. People, you know, we have all this kind of, you know, you emotions are tied up with eating. It is really, really hard. So I would say get some support, make sure your family are supporting you. And if anybody is going to say, oh, just do it, you know, you've got to have the confidence to say, it's really, really hard and I'm trying. And any support that you can get off some people you live with or in your family or your friends, and by joining a group, is going to be helpful. But yeah, absolutely, take a look on the Verity website. And actually, we're going to be organising a series, a webinar series for nutrition and focusing on things like PCOS. So keep an eye out for that. And as long as your kind of Emma's got your email address, you'll get updates about that and you can book on. So this is going to be a series specifically for people with BMIs that are above 30 and really need to lose weight to progress with treatment. So it will be specifically for you. So keep an eye out on that.
Sorry. Okay, so this is just something. So today has been really helpful to understand, you know, what, and that's so great to hear. And so in the last 3 years, I've had an ectopic pregnancy and 2 miscarriages. So could you do another webinar in the future about pregnancy loss? Well, we are actually, Alice, aren't we, talking about running a support, peer support group, you know, for sort of pregnancy loss, and we are certainly looking at these things. So, you know, I do have your email address, so yeah, I will absolutely, you know, let you know. But if you'd like to be added to our mailing list, please do email me and ask me, you know, to do that, so that I can ensure that you get the correct information, you know, when we do launch sort of those support groups.
Okay. What advice do you have on how to talk about it with family and friends of our own? Sometimes I find it even difficult to speak to my own husband. Fertility Awareness Week has helped us talk through, and today's talk. Yeah, it is. It's about talking. It's about having those conversations, trying to speak about it maybe when you're not really upset, because what we see a lot of the time, Emma might want to add more on this, is one minute you're fine and you're coping with it all. You've got your appointments, you know where you are, you've got your plan, you're doing your thing for your kind of your lifestyle, and you've got your mission. And the next minute something happens, like Emma says, you walk in and you see somebody breastfeeding, or you see baby clothes or whatever it is, and it's like, oh my goodness, and it just hits you like a train. So I think it's about maybe choosing the moments where you're not feeling really it's not heightened, and maybe when you're feeling okay, maybe then at that stage have conversations. Emma, what do you think?
I couldn't agree more, Alice. It is choosing the you know, the days where you feel a little bit stronger, where you feel you know, like you can be a little bit more open about it, and going with it, and it is, Alice, as you said, it's all about talking. It's all about sort of, you know, and it's so hard to do. You know, it's so, you know, it's easy for us to say, you know, yes, it's all about talking and putting your cards on the table and being open and honest, but that is an incredibly difficult thing to do, especially when a lot of the time you don't know how you're feeling yourself, do you? You know, and so how can you then tell somebody else about how you're feeling and how you and what you're experiencing when you're sometimes at a loss to how you're feeling, you know, yourself. So I think, again, you know, the key thing is to go easy on yourself. You know, this is an incredibly difficult thing that you're going through, but as and when you do feel that you are able to, on those days when you don't feel so as emotionally burdened, you know, yes, then maybe talk about it then. But if you want any support from us in terms of, you know, doing that or building some confidence in doing that, then just let us know.
Yeah, absolutely. And also another thing I want to add, like with regards to speaking about it with your own partner, I think we mentioned it before, you know, men can find it really hard because they're not going through kind of all the invasive stuff. But it's important to remember that even before you knew there was an issue, as soon as you started trying, as a female, you were probably acutely aware of every single feeling in your body. Oh, my boobs feel a bit sore. Oh, I feel a bit sick. Oh, I got a metallic taste. And you're aware of these things from the very start. Now, you're so aware of these feelings. When you say these things to your partner, oh, my boobs, for him, it's probably a lot of just noise because he's hearing this stuff from you all the time. But it's so important, you know, to remember that for you've got these feelings buzzing around your head. You can feel them. When you're having treatment, you can feel the effects. So I think if you can be honest with your partner about this, then and say, listen, I'm going to be talking to you all the time about how I'm feeling. You don't always need a response. I think it's important, just both of you, you know, male or female, just remembering that you're going to experience this differently, and it's about just coming together, like Emma said, when you're feeling strong, talking about it, and not necessarily expecting the male to really understand how you feel, because he's not going to feel all those things. So I think it's just having an awareness of that as well.
Yeah, absolutely. I've got a few sort of messages that have been sent, you know, privately here, and so so it says, well, thank you, you know, for this opportunity to learn more about, you know, IVF. Our daughter and her husband have had 5 attempts. The last 2 resulted in a positive pregnancy test, but then after 7 days, she had a miscarriage. They are going to try again, but why would this happen? She is so devastated. And I'm just so sorry for what you're all going through, you know, because that is just so incredibly difficult. And it's really hard to understand, you know, like I mentioned, you know, in my presentation, you know, why, you know, why us? Why has this happened to us? Because it isn't fair. I haven't got an answer in terms of why, you know, this has happened, you know, in terms of the medical side, you know, of why miscarriages happen, you know, maybe, you know, Ariana could possibly, you know, come in there, but these things are so difficult to deal with, and we are here for you, and your daughter, and if they need support to get yourselves through this, you know, you just let us know. Alice, did you want to, or Ariana, add anything, you know, to that?
Yeah, I would like to add just quickly. As I said in my presentation, when we transfer the embryo, and it's a good embryo, these embryos got like 1 in 2 chances to implant, but unfortunately things might not go right, and at the very beginning of the implanting, the embryo might stop growing, or the environment might not be favorable to the implantation, and that is when the original positive test turns into negative, and that is called biochemical pregnancy, when it happens really at a very early stage. Obviously, if the pregnancy progresses a little bit longer and it does cause a miscarriage, again, that's something else slightly different. But 2 pregnancy loss will also already possibly qualify for further investigations, even if the guidelines, the NICE guidelines, recommend investigations after 3 miscarriages. For us, for the IVF specialist, when we see two pregnancy losses already, we would like to investigate a little bit more before progressing with new treatment.
Thank you. There's another one as well. There appears to be no words of comfort to offer when a pregnancy fails. How can we support in a positive way when we are dealing with a bereavement? Just be there, I think, isn't it? I think it's important to remember that whatever stage you lose your pregnancy, so whether you have a negative pregnancy test after the 2-week wait, or whether you're pregnant with a baby, your baby, and then you lose that baby, it's all loss. And I think that's what you can do as family members, is recognize, no matter what stage your loved one is at, if they've had a loss, that loss is real, and it doesn't have to be a 20-week miscarriage to feel devastated. Somebody can feel devastated when they do not get a positive pregnancy test. There is no hierarchy of grief and sadness. Everybody's feeling is real, and we're all entitled to feel bereaved. So I think if you can just understand that and say, we are here, we can't even begin to imagine how you're feeling, but if you want us, you just want to scream and shout, if you want to cry, we are here. Emma, anything else?
Yeah, absolutely. I think ultimately, you know, exactly what you said, Alice, and it's that support, knowing that you've got that support, you know, as and when you need it. And I think an understanding that sometimes maybe your loved one isn't going to want to talk about it, because certainly, you know, they might need to be dealing with that privately, you know, and work, you know, their own emotions out for a little while. But if they know that you are there when they are ready to talk to you, that's going to be huge for them. And yeah, you know, it's together, you know, I think is the best way, you know, forward, you know, as best you can, isn't it? I think, Alice, I've seen, this isn't actually a question, but I'm really keen to read it out, because it's really positive, and I think it's, you know, something that will give a lot of people, you know, a boost. And I think, so this has been so useful and informative. We're currently going through treatment, and lots of our friends and family have joined today. And even just knowing that they have taken the time out today has meant so much, knowing that they are there for us and want to learn. So thank you to all those that have joined today. I think it will have meant a lot to your loved ones, and I could not agree more. What you have done today for your loved ones is incredible, you know, and they are going to feel more supported as a result of you joining today than you will ever know. So I just really wanted to read that out, because I thought that was a really important message. Alice?
Okay, our investigations have been really delayed due to COVID-19, and then issues with multiple swabs being done incorrectly. Is it possible or easy to move between private and NHS care for investigations to treatment, or should we just try and be more patient? We would all like to be more patient, wouldn't we? You can, it depends. I think it's probably best to do a follow-up one with Emma on this, send her an email, because we'll get you all the information. But essentially, the criteria in Wales for NHS funded treatment is up to 2 full cycles of IVF or ICSI for women who are 40 or below, and up until your 43rd birthday, so over the age of 40 to 43 essentially, it's 1 cycle. Now, if you had a private cycle done prior to NHS treatment, you could have a cycle and it wouldn't impact your eligibility criteria. But if you have more than 1 cycle, you need to be careful, because the NHS will not fund your treatment if you have more than 3 cycles. Because NICE recommend 3 cycles as the best, to give somebody the best chance. So if you have 1, you would still be entitled to access your 2 full cycles on the NHS. But if you had 2 privately funded cycles of treatment, the criteria would then mean that you could only access 1 funded NHS cycle. It's quite confusing. Ariana, you might be able to say that a bit clearer than me.
Yeah, no, unfortunately, I think this is what it is, because the NICE guidelines recommend 3 cycles. If you have all the 3 cycles privately, and I know some clinics privately offers these packages of buy 2 get 1 free, or buy 3 get 1 free, that will actually affect all the eligibility for the NHS. So 1 cycle privately is fine, it doesn't affect anything at all. 2 cycles privately, it's fine, but you will lose 1 NHS cycle, so you will always be entitled to 1 if you are below the age of 40. 3 cycles privately means no cycles at all. If you are between the age of 40 and 42, 43rd birthday, and you have had 1 cycle privately, you will not entitled to any NHS cycle.
Thank you, Ariana. How much does a private IVF cycle cost? Oh, it's about £5,000, Ariana?
It does vary, because some centers include the cost of the medications, and some centers, in some centers, the medication is excluded. What I would like to say, actually, which is very important, is that there will be a new law regulating IVF, the financial implications of IVF treatments and IVF testing and adds-on. And this new law is at the moment out for opinions with the different stakeholders, and it will become law in March 2021. So all the IVF units that are offering private treatment will have to obey to the new law, and part of the law is actually be more transparent on what is included and excluded in the price of an IVF treatment. So that will have to be very clearly explained in the website or in the price list, and very, very detailed. So just watch this space, because things are developing in the fertility field privately as well.
Thank you. Any more questions, or we're done on the questions? If anybody else now wants to type anything in or ask, if you can unmute if you prefer and ask. Okay, well, I think that's it. So again, we just want to say thank you so much for joining us on this Life on Hold event. Fertility Network UK are here for anybody, like we say, anybody affected in any way. And as friends and family, you are affected by this because you love your loved ones, and it's hard, and we recognise it's hard for you. So we are here. Any questions, any feedback, any suggestions, send an email over to Emma. She loves a bit of extra work, don't you, Em? So no, please use us. That's what we're here for. Yeah, thank you so much.
Thank you.
Thank you.
Thank you.
It's still going on.
Thank you.
Thank you.
Thank you all.
Thanks.
Thank you. Bye-bye.
Bye. Thank you very much. We'll stop the recording, Em.